My name is a.geeslin. Today I am presenting Module 8 assignment for Ms. Mischer's N494 course at Aspen University. Objectives are as follows. The first article is Violent Events, Ward Climate, and Ideas for Violence Prevention Among Nurses in Psychiatric Wards. Negative impact of violence. Violence against psych nurses is a global issue. 70% of nurses experience non-physical violence, 40% experience physical violence, and 20% of patients are violent. Staff, other patients, and objects are subject to violence. Psych units are lockdown units with many restrictions. These restrictions provoke aggression. Nurses must know the warning signs and triggers for prevention, early intervention, and effective de-escalation. During violent episodes, nurses must seek help from other staff, attempt to de-escalate the situation, and if unsuccessful, resort to restraints, seclusion, or forced meds. Violent events can cause staff to become physically and emotionally overwhelmed, reducing the quality of care. Nurses suggest more in-service training, enhancing competent interactions, and increasing staff presence. Article 2. Barriers and facilitators to the effective de-escalation of conflict behaviors in forensic high-secure settings. Psych patients are involuntary and locked down. They have many demands and expectations. The first line of defense is aggression and requires de-escalation. Violent behaviors that are unmanageable require seclusion, restraints, or forced meds. Facilitators to de-escalation are competent engagement, regulating own emotions, becoming knowledgeable about patient diagnosis, acknowledging patient triggers and past traumas, and creating a culture of positive risk behaviors. Barriers to de-escalation are risk management restrictions and rules of confinement, idle time, wide open environment, and power and control. Article 3. Identifying patients at risk of inpatient aggression at the time of admission to acute mental health care. Most violent behaviors occur within 24 hours of admission. Behaviors that are exhibited 2 weeks prior to admission correlate with aggressive behaviors the patient may exhibit on the ward. It's essential for nurses to identify triggers, warning signs, and previous violent events. The BPRS and BVC are scored to assess violent risks. The overt aggression scale is used after a violent event to determine warning signs, triggers, and severity. Again, the BVC, BPRS, and previous violent events are predictors of aggressive behaviors. Article 4. The therapeutic needs of psychiatric inpatients with psychosis. Patient and staff violence-related themes. Psychiatric nurses and their patients have their own perspectives on priorities of care and the barriers impeding quality care. Patient perspectives. They believe nurses need to fully understand their reason for admission and behaviors leading up to it. They need individualized care based on their diagnosis. Patients are often left feeling confused and distressed upon admission, and they often feel like there is lack of collaboration of care and reduced patient control. Staff believe that the restrictive and rigidity of care, resources and privacy, lack of collaboration and teamwork, training and staff support, formal assessments, and treatment plans each need to be enhanced to provide quality patient care. Top priority is allowing patients to feel like they have some power in their treatment. Treatment needs need to be more focused on social, cultural, religious, and traumatic issues. Care needs to be more trauma-informed. Article 5. Quality Improvement in Forensic Mental Health. Factors and effects related to violence. Violence takes a toll on safety and well-being of staff and patients. Clinical care is negatively impacted, and the hospital community is directly and indirectly impacted. Violence risk factors include gender, diagnosis, limit setting, lack of communication, denied services, substance use, and patient-to-staff ratios. There are many significant differences between mental health units and general medical units. Safety Huddles is an intervention for violence. 10 to 15-minute staff briefings on relevant safety information are discussed. Huddles occur once a shift unless an additional meeting is required due to a sudden concern. Safety crosses are recorded and demonstrated and color-coded for type of event. They mark daily, weekly, and monthly progress. Details of events in progress or lack of progress are presented at monthly meetings. Weekly safety discussions review safety crosses and discusses events in detail, shares thoughts and emotions and values around events, reflects on events and learns from them, and celebrate periods without events. The benefits of interventions: induces collaborative learning, provides opportunity to reflect, provides opportunity to evaluate progress, challenges, connects, and learns factors related to violence, enhances understanding and why it occurs, provides enthusiasm and continued participation, and overall the work culture improves. Article 6. Enhancing the safety climate and reducing violence against staff in closed hospital wards. Safety climate determines how staff view safety values of an organization. They're reflected through staff behaviors, elimination of safety breaches, and policy and procedures to reduce hazards. A 3-day training program is implemented to enhance staff education and skills. Post-training results: safety climate measures significantly improved, violent episodes were reduced by 2/3, 43% reduction of injuries in a 6-year time span, and increased patient and staff satisfaction measures. Practice change based on the previous evidence-based practice articles. Clinical practice change: implement new hire and annual training covering early intervention and de-escalation techniques to reduce harm and improve the well-being of staff and patients. Implementation plan: developing a vision for change. We work with the highest risk patients in the hospital. 20% of our patients express violent behaviors. Goals within the next 2 months are to reduce seclusion and restraint events by 30%, have 80% participation in completing risk assessments, and improve patient and staff satisfaction. The leadership team involves management, safety members, quality improvement, risk management, and outside experts. Promoting engagement. This involves the following priorities: infrastructure, and mentors. Integrating practice change. Disseminating evidence. The following evidence is presented to staff for EBP change. Clinical tool development for integration of change includes BBC flow sheets, BPRS flow sheets, OAS flow sheets and progress notes, and admission note templates. Pilot testing includes changes in flow sheets and admission note templates. Training and safety team members will only be available on adult units, and once improvements are made and plan is successful, will then implement on the geriatric unit and in the emergency department for use on potentially or current violent patients. Integrating change, celebrating success. Celebrate improvements in the milieu behaviors, reduction of seclusion and restraints, and improve patient and staff satisfaction rates. Each month, review the successes and failures, learn from the failures, and celebrate the successes. Evaluating practice change. Overcoming barriers to implementation. Lack of knowledge and skills, reluctance to change, and poor attitudes are main barriers. To resolve these barriers, use evidence-based practice, bring in experts, provide short-term goals and successes, and involve outside resources. Outcome measures, quality care improvement and patient-centered care, efficiency of processes, environmental changes, and professional expertise are each ways to evaluate practice change. Internal evidence demonstrating improvement in outcomes, improved patient satisfaction surveys, improved job satisfaction, enhanced knowledge, skills, and confidence to conquer aggressive and violent behaviors, and a calmer and more engaged milieu. Ethical considerations include approval from the Ethics Committee, beneficence, non-maleficence, autonomy, and justice are maintained, management, quality improvement, and risk management monitoring are used throughout the change. The model for evidence-based practice change is the theoretical model used. I assessed the need for change, located the best evidence, critically analyzed the evidence, designed practice change, implemented and evaluated change in practice, and integrated and planned to maintain change in practice.